Dr. Waisman, University of Wisconsin Medical School and Department of Pediatrics. These are my two patients, Keith and Kay. Both children were diagnosed as having phenylketonuria. But Keith was diagnosed at 3 years of age, and his IQ is now about 40. Kay was diagnosed at 2 weeks of age, and she is now 4.5. The psychologist who just finished testing her tells me her IQ is 106. As a pediatrician, phenylketonuria is not a statistical rarity. Kay is nearly normal now because we were alert to the fact that phenylketonuria could occur again in a family with PKU. Luckily for Kay, the diagnosis was made early, but there must be others who are not yet diagnosed and who could be helped. The important point is to detect phenylketonuria early, and I think that's why Kay is as good as she is today.
There are a number of tests for PKU. One of the simplest is the diaper stick test. This simple test will show positive if the child is a PKU. The difference for the infant who is not treated is a lifetime of imbecility. For the public, this difference means immense sums of money for institutional care, hopeless lifetime care. For the physician, this difference means the personal satisfaction of detecting a rare disease at an early stage. This disease can be detected, and the complications of this disease can be prevented. Phenylketonuria, PKU, is an inborn metabolic error. Its immediate result, quite possibly from the first day of infancy, is severe brain damage. The disease is transmitted as a recessive trait. But the metabolic error itself is a deficiency of a single liver enzyme, phenylalanine hydroxylase. This enzyme is necessary for the normal conversion of phenylalanine to tyrosine. When this enzyme is missing, the reaction does not proceed to tyrosine in the usual manner, and the result is a rapid accumulation of excess phenylalanine in the blood. But more seriously, there is a rapid concentration of excess phenylalanine and its byproducts in the brain as well. Both of these concentrations may run 20 or 30 times above normal, and for the developing brain of the child, the result is almost certain brain damage. How the brain is damaged is not yet known, but the end result in the PKU child is only too well known. The untreated PKU child will probably never have an IQ above 40. Fortunately, this excess of phenylalanine can be detected in the infant's blood as early as the 5th day of life. By the 3rd week, the blood level is high enough so metabolites of phenylalanine, such as phenylpyruvic acid, will appear in the urine. As far as signs and symptoms are concerned, most PKU children tend to be fair-skinned, blue-eyed, and very blonde, because the same metabolic disorder interferes with normal pigmentation. But there are many exceptions. There are some dark-complexioned children with PKU. Eczema and severe skin irritations may appear very early. The physician can detect a musty odor from the body and urine of the PKU child. There are, of course, neurological symptoms in most untreated PKU children. Usually, both the superficial and deep tendon reflexes are greatly accentuated. There may be EEG abnormalities. There may be convulsions. It is important to realize that any of these symptoms, but not all, may be observed in any one patient. Furthermore, because phenylketonuria is an hereditary disease, the need for speedy detection is mandatory. PKU is transmitted as a recessive trait, an excellent example of an inborn metabolic error. Actually, more than 80 inborn metabolic errors are now known. For reasons still not understood, one gene is absent in the PKU carrier. Each time when two parents with the PKU trait have a child, there is one chance in 4 that the infant will be a PKU. One gene in the chromosome of each carrier is missing. On strictly genetic principles, it is possible that none of the children will have PKU. It is equally possible that all of the children will have PKU. Therefore, the physician seeing a family with a history of PKU must be especially watchful. Newly born infants in such a family should have a phenylalanine blood test each day for the first week and on alternate days until the third week. A blood level diagnosis can be made in the first week if the child is a true PKU. If for any reason the new infant in a high-risk family cannot be immediately diagnosed, a low phenylalanine diet should be started anyway. Careful statistical studies have confirmed these facts about PKU beyond all doubt. We know that approximately 1 out of every 100 adults in this country carries the recessive trait for PKU. We know that the chance marriages of these carriers have produced, in this generation, from 3,000 to 5,000 PKU mental defectives. In the past, most of them have been in institutions. From a physician's point of view, even more important is the estimated frequency of the disease among new infants. Approximately 1 child in every 20,000 births. But again, the statistics are of small consequence against the human loss. In the infant with PKU, the brain is damaged so rapidly in the early weeks that literally every day counts. Notice how the final IQ drops the longer the PKU child remains untreated. The key is early detection. For the physician who routinely sees infants, a number of tests are available, including the stick test, ferric chloride, 2,4-dinitrophenylhydrazine, bacterial inhibition, and quantitative plasma analysis. The stick tests are simple, inexpensive, 95% accurate, and easy to use. They should not be rubbed on the diaper, but completely moistened in the urine in the diaper. A yellow reaction is normal and negative. But notice how the positive urine gives a dark blue or green color. All infants should be tested at the first visit, preferably no later than the 4th week. Of course, if a urine specimen is available, the stick may be dipped and then also compared with a color chart, which is supplied to eliminate any possible error. It is recommended that a urine test be done on an infant at successive office visits until the 3rd month of age. Metabolites of salicylates and some other drugs also cause color reactions. In the ferric chloride test, a drop of 5% ferric chloride on a wet diaper from a PKU patient will give a positive test, dark blue-green, in 10 seconds. Again, if a urine specimen is available, a ferric chloride solution may be added directly to it. The 2,4-dinitrophenylhydrazine test requires liquid urine. When the urine specimen from a PKU patient is mixed with a test reagent, a white precipitate is formed. This indicates a positive test for ketones. Studies are now being conducted on a bacterial inhibition test using blood, the so-called Guthrie test, which, if it proves practical, will allow testing of newborn babies before they leave the hospital. The physician should recognize that this bacterial inhibition test requires special laboratory equipment. Then, of course, any positive test must be confirmed by a quantitative plasma analysis as soon as possible. This is now done in many hospitals and laboratories. The plasma test will measure accurately the level of phenylalanine concentration and then confirm suspected PKU. The control of this blood level within normal limits is important for success in managing the disease. Because phenylketonuria can be controlled, brain damage can be prevented or kept to a minimum. This treatment consists of a low phenylalanine diet specially formulated to be nutritionally adequate. For infants, a low phenylalanine milk substitute formula is available. But for older infants and children, low phenylalanine solid foods, such as fruits and some vegetables, are added to supplement the low phenylalanine milk. Recent evidence points to the possibility that the PKU child may be taken off this rigid diet when the child begins school, without danger of further deterioration of intelligence. At present, there is no alternative to this carefully supervised treatment, which is balanced between just enough phenylalanine to support normal growth and not enough excess to cause brain damage. This is a delicate balance. So delicate is the blood and dietary control of the PKU patient that the practitioner would best refer these patients to a mental retardation clinic. But the detection of PKU cannot be left only to clinics, nor can the routine testing of well babies cover any population smaller than all new infants. Testing for PKU must become as routine and as standard for general practitioners and pediatricians as shots for DPT, polio, and smallpox. Testing must be done routinely. Testing must be done no later than the 4th week of life. There is now the exciting possibility that the conquest of PKU will be an opening key to even more discoveries in the biochemistry of mental retardation, a first and fundamental step in reducing its staggering misery and cost. For the general practitioner and pediatrician, there can be the personal satisfaction of knowing that no undetected PKU will escape his routine examination. Urine tests are now available in quantity at a very small cost, which are to be used no later than the 4th week. The special low phenylalanine diets are widely available, and in some states are even furnished at public cost if necessary. Statistics alone cannot determine when a physician will detect a PKU infant. Phenylketonuria is an inborn metabolic error with consequences that could be completely prevented.
I feel personally, because of what we now know about PKU, that the detection of this disease is not only good medical practice, but the professional responsibility and social responsibility of all physicians who see children.